Hello, everyone. Hello to the time travelers all around the world who are joining us in today's conversation with Richard Horton, the editor-in-chief of the Lancet. A great honor to have you here. It is my great pleasure to introduce the moderator of this event, Professor Alfred Tauber, who is a professor of medicine and a professor of the philosophy of sciences at Boston University for many, many years. But Fred's crowning achievement was that he survived 6 years as chairman of our board here at the University of Haifa. And no good deed goes unpunished, Fred. You are constantly called upon. This, by the way, is very far from punishment. It is a delight to have you moderate this event with Richard. And with no further ado, I'm passing the event over to Fred. So welcome, everyone. Fred, you are on mute.
Okay. Am I on now? Can you hear me?
Yes, we can.
Okay. So Richard, welcome to the University of Haifa, to the Board of Governors meeting. We're very, very pleased to have you. I'm very pleased to introduce you. Although a short biography was sent to everyone as a prelude to this meeting, I'd like to just mention a couple of things which were not included. You've actually been the editor-in-chief at the Lancet for 25 years, since 1995. And you were a young man when you assumed that position, which is also rather extraordinary. I have actually been reading you not only in the medical literature, but your work in the Times Literary Supplement, the New York Review of Books, the Observer. These are all places where your experience and wisdom has been transmitted to a wider audience. Your activities regarding COVID, I think, are particularly important at this time, but I think more generally, your experience with WHO, serving as chairman of the Scientific Advisory Group, put you in a very good position, I think, to evaluate what was going on. And in late January, you really did sound the alert. You were among the very first. The Lancet published some very important papers which predicted what was going to happen. And the fact that Europe, United Kingdom, and of course America lagged behind the Asians in this regard is a long story, one that has still not fully been disclosed, but a very important one. So we are very, very happy to have you both in terms of your general knowledge, but in particular with the COVID experience that we're all dealing with. So welcome and proceed as you like.
Fred, thank you so much. And Ron, thank you for the invitation. And I'm only sorry that we can't be all together in Haifa. One of the most beautiful cities in Israel. I've visited on many occasions and look forward, I hope soon, to be able to return. So it's a great, great privilege to be with you. Well, the quote of today comes from Albert Bourla, who is the chief executive of Pfizer, who said in a press release, "Today is a great day for science and humanity." And their press release reports an interim analysis of their vaccine where they claim it is 90% effective. Well, we'll have more to say on that in a few moments. But I want to, if I may, try and answer 5 questions over the next 20-25 minutes. First, what's the current situation with COVID-19? Second, what are the lessons that we could learn so far? Third, let's be very honest with ourselves and say, what could we have done better? Fourth, what's the end game? And that's where we'll talk about the vaccine. And finally, what should governments do now? Now, I should give you a spoiler alert. The answers to those 5 questions may sound a little pessimistic, but I want to say at the very beginning, before I answer those questions, that actually I'm quite optimistic about the future. And the reason why I'm optimistic is history. because if you look at the history of pandemics and what happens after the pandemic is over, then you see some very interesting positive signs, because societies change after a pandemic. The old society has been erased and has given birth to a new society. And out of the tragedy of a pandemic, there will be new societal beginnings. That was true in 1918, after 1918 and the influenza pandemic. And it was certainly true if I go back to 1665 and the Great Plague of London. Pandemics change governments. Lessons are learned, at least in the short to medium term. And pandemics change the public. They change the public because now health is a bigger priority for the public. The public demand more investment in social protection. And the people who have been at the margins of society, typically, people who are usually unheard, invisible, they move to the political center stage. And indeed, they already are moving to the political center stage. It's interesting if you go back and look after 1918 and the influenza pandemic then, because that event accelerated the pace of political and social change in many parts of the world. It laid the path for a clamor for universal health coverage and taking public health more seriously. Interestingly, it led to an artistic renewal, a burst of artistic creativity, and actually created the conditions for nothing less than a global regeneration, a commitment to multilateralism, and set the path on the way to the birth of the United Nations and the World Health Organization. So that's the optimistic bit. Now let's try and answer the questions for today. So the current situation, as of today, we are close to 50 million cases worldwide, over 1.2 million deaths. If you look at the curve of new cases, they're still rising globally. We still haven't reached the peak. So we're right still in the middle of this raging pandemic. The Americas have been hit hardest, as you know, 9.5 million cases in the United States and rising, 5.5 million cases in Brazil. I'm afraid that my own continent, Europe, has been very badly hit. France, 1.7 million cases, Spain, 1.3 million cases, my own country, the United Kingdom, 1.2 million cases. And then Europe is followed by Southeast Asia and India, a horrific 8.5 million cases. The highest mortality rate is Belgium with 113 deaths per 100,000 population. But if you look at the top 10 countries, a terrible league table, the top 10 mortality rates, out of those 10, 7 countries are in Latin America. In Europe, after Belgium, the highest mortality rates are in Spain and the United Kingdom. America's not far behind. But interesting when you look at Israel, because my country has a mortality rate of 74 deaths per 100,000. Israel has a mortality rate of 30 deaths per 100,000. Your mortality rate is more than half of the United Kingdom's. So that's a very interesting observation that we might want to return to and discuss later. Now, we all know that this is not just a health crisis. It's also an economic and indeed a political crisis. And there is still the opportunity, the possibility, as the pandemic worsens in some countries, of a breakdown in public order. The economic costs are just huge, and the World Bank estimates that over 100 million people will be tipped back into extreme poverty. But of course, the effects will be much bigger than those 100 million people. Many of our societies are seeing those in the most precarious situations really go through terrible suffering. And we have seen that this virus has a predilection for hitting those in the most marginalized, disenfranchised parts of our communities, worsening inequalities, disproportionately hitting the poorest, especially affecting indirectly women and children. 80 million children worldwide are missing their essential vaccinations. Over 1 billion children worldwide have been prevented from going to school. And we have the shadow pandemic, while people have been working from home, told to stay at home, a terrible increase in domestic violence, intimate partner violence. So the conclusion I think one can draw from the current situation is that I don't think we've anywhere near faced up to the scale of the crisis we face and the nature of the transformation that this virus has brought to us. And we're also in the middle of a dispute, and a dispute about our strategies for addressing this virus. Pitted on one side, often those in the medical or health community who are desperately worried about the impact on health and well-being caused by this virus, and who tend to be in favor of lockdowns to try and suppress the prevalence of the virus in the community, versus those who would prefer to put the economy above health, or at least next to health, and propose a more libertarian approach, whereby we would allow a return to normal functioning or relatively normal functioning in society to protect livelihoods as well as lives. And this battle between these two wings in our communities is being fought out actively right now. We certainly have it in my country, the United Kingdom. We've seen it in the United States, and President-elect Biden will have to find some way of navigating between those two extremes in his country as he goes through a terrible, terrible humanitarian tragedy. So what started off as a health challenge with the need for technical solutions has now become this political challenge, which is in many ways and in many countries paralyzing our ability to address the pandemic. So what are the lessons then? Well, one lesson I think is that society is very brittle. It's much more brittle than perhaps we once thought, because it has revealed to us who really is vulnerable in our society. This pandemic has held a mirror up to our society. Older citizens, those living with chronic disease, Black, Asian, and minority ethnic communities, the poor, key workers. I mean, you can see that I'm sitting in a room in a house in London, able to do my job, able to meet with you. But if I worked in a supermarket or worked on a bus or worked on a tube train or worked in a hospital, like many of you perhaps do, it's not so easy. So the people who really keep our society going, who really prevent our society from disintegrating, we've seen who those people are. A second lesson is, and I perhaps surprisingly to you say this, that COVID-19 is not a pandemic. And what I mean by that is that it's not a simple epidemic of an infectious disease. It's more complicated than that. It's actually a synthesis of two epidemics. One is the virus, the coronavirus, but it is interacting with a set of chronic diseases, heart disease, high blood pressure, diabetes, obesity. And if you have one of those diseases, the virus is much more pathological, much more severe disease is caused if you have one of those underlying diseases. In addition, that interaction of two epidemics is taking place on a background of inequality. It is the poorest people in our society who are affected. That synthesis of epidemics and the connection between the biological, the disease, and the social gradient, the inequality in our society, that is a syndemic. So that is what we're trying to deal with, a much more complicated picture than is perhaps presented. What that means is that if we're going to solve this problem that we face, the solution will not simply come from dealing with the virus. The solution to truly protect our communities will come with dealing with the overall health of our communities and reducing the disparities that our communities face. A third lesson, and this is a little bit of public relations for science, if I may. Science has been critical to shaping the response to this syndemic. The first paper we published was on January the 24th, describing the first 41 cases of COVID-19. If you go back and read that paper, you can see that the whole story that's evolved over the past 10 months was actually described in that opening paper. Multi-organ failure disease, a brand new virus, no treatment, no vaccine, patients tipping into hospital, ending up on intensive care, requiring ventilation, the need for personal protective equipment, the urgency of getting a test, trace, and isolate system up, person-to-person transmission, the connection with SARS back in the early 2000s, and the danger, the risk of a global pandemic. We knew that whole story in the last week of January, and yet it took often weeks, in some countries' case months, before that warning signal was taken seriously. But science, over the last 10 months, has made the most enormous contribution to shaping the response of governments. And with today's news about this Pfizer vaccine, it truly is unprecedented. It usually takes somewhere between 7 and 8 years to develop a vaccine. And here we are, November, and we didn't even know this virus existed in 2019. It's a remarkable story. Now, what could we have done better? Because clearly many countries, perhaps most countries, were sadly not prepared. The key needs that you require to protect yourself in a pandemic, we do know. These are not a surprise. We've known them for many decades. You need a surveillance system, you need laboratories, you need a health system with enough capacity to deal with ill patients. You need qualified health workers, nurses and doctors and many others. You need a strong research system with scientists who can then channel their advice into governments. And you need strong social capital, strong communities with a sense of solidarity and trust. And yet, many of those elements we either didn't have or they were weaker than we thought they were. And that's what has accounted for the terrible toll of mortality in so many countries. And that combined with the fact that we didn't take the signs coming out of China in January seriously. Now, a second aspect that we could have done better, and I still remain surprised, indeed shocked about this, there's been absolutely no global coordination of the response. A global emergency such as coronavirus, demands a global response. Now, the World Health Organization did an exceedingly good job, the fastest it's ever worked, in declaring a public health emergency of international concern by the end of January. They sent out the most significant signal red flag to the world in January, and most countries paid no attention to it. So that wasn't WHO's fault. But then what happened? WHO left 195 countries in the world to fend for themselves. And there has never been a moment when countries have come together to actually share their experiences, to learn from one another, to fashion a global response. In fact, it was only in the past week that it was decided that in early December, there will be the first United Nations Summit on COVID-19 that will take place on December 3-4. But it's taken almost 12 months to get to that point, which is truly appalling. No coordination whatsoever. And a third aspect that we could have done better, and this is always underestimated in public health, and that is improved communication. Communication is absolutely critical to building trust amongst the public in the face of an emergency, especially in the era of such a changed media and social media landscape. Government leadership, effective government leadership, crucially depends upon the clarity of the messages they send out. There have been good examples of this. New Zealand and Prime Minister Jacinda Ardern, for one. But in many countries, I'm afraid there's often been absent leadership, U-turns, confusion, and breaches by those in power of their own advice. Now, what about the end game? Now, this vaccine that's been announced today, this is what's called an interim analysis. So that means that it's not the final bottom line on the study. Although it's true that it seems that there might be 90% effectiveness, the fact is that we haven't seen the full data yet. We don't know whether the vaccine is effective in all age groups. Often those who are older have a phenomenon called immunosenescence, whereby the immune system doesn't work as well as in a younger person. And so we don't know whether that's the case with this particular vaccine. So I would say that I'm cautiously optimistic, but one lesson that we really do need to embrace, and I know this is going to sound pessimistic, a vaccine is not going to be a simple magic bullet to eliminate or eradicate this coronavirus. It will be an important tool to help us deal with this situation, but it will not be a simple tool that can erase this situation. At the moment, there are currently 11 vaccines in final stage clinical studies. The Pfizer vaccine is one of those 11. There are something like 40 or 50 in early clinical trial development, and there's well over 100 in preclinical development. So we have every reason to be hopeful that there will be more than one vaccine that we can draw on, but there are some threats. We're seeing already the rise of a re-energized anti-vaccination movement, and that anti-vaccination movement is having an impact. It is reducing the confidence of the public in the safety and efficacy of a vaccine. So we need to welcome the possibility of a vaccine, but we need to also be aware that this virus is now with us for the long term. It is endemic. The goal is to reduce community transmission A vaccine will help, but it won't be a simple solution. So what should governments do now? I'm drawing to a close. What should governments do now? First of all, I think governments need to manage this predicament as a syndemic, not simply a pandemic, addressing chronic illness and inequality as well as the virus. Second, they need to pay much more attention, that is governments, to investing in the basics of public health systems, surveillance, the workforce, the health system, laboratories, and science policy. And our universities are absolutely crucial to that. Our universities, investing in our universities, that's the foundation for investing in the technical capacity, both people and equipment, for those key public health elements. And a third thing that a government should do is we need to think about ways of remembering. 1.2 million people have died during this pandemic, and we need to find a way to reclaim the biographies of those who we've lost. We've presented these data, and I've talked about it this way too, as league tables, statistics, and as a result, we've radically dehumanized the impact of this virus. We need to rehumanize COVID-19 in order to truly learn the lessons of it. So to close, I began optimistically and I want to end optimistically. As you very kindly mentioned, Fred, I've edited the Lancet for 25 years. And I've never experienced in my time at the Lancet the sense of cooperation and solidarity and unity of purpose that I've seen from the international medical, scientific, scholarly community these past 10 or 11 months. It truly has been inspiring to observe the way that community has come together to address this problem. COVID-19 has definitely challenged us all. It's revealed the best of us, though, too. It's not our destiny. COVID-19 is not our fate. It's actually a moment to rewrite a different future for our families, our friends, and our communities. And not just for ourselves, but for generations to come. Thank you very much.
Thank you very much, Richard. I am fielding questions and comments, and I already have accolades from someone from Los Angeles who said this is the best presentation that he has heard about COVID. So on that positive note, I will begin. I'm assembling the questions, and while I do that, I'd like you to just address the last point that you made concerning the cooperation amongst the biomedical community and amplify that, because I'm not sure that our listeners appreciate how extraordinary this has been. Now, there's obviously a lot of competition to develop the vaccine, but to get to the vaccine, a lot of basic science had to come together as well. Would you care to comment on that just for a moment?
Yeah, absolutely. So I think there is this phenomenon in science called open science. And open science is about trying to promote a culture where there's more transparency around data, there's more collaboration, there's more engagement between scientists and the public. There's more availability of data for people to be able to reuse. And I think COVID-19 has been an incredible test case for open science. And it's true. All of the research that has been published, and there's been an enormous volume of research published this year on COVID-19, has all been made freely available by researchers, by publishers. we've seen this extraordinary engagement between scientists and policymakers and the public. I mean, nobody in the public usually reads the Lancet. I can tell you it's a very dry, technical, scientific journal. But the fact is that suddenly, when we publish research, it's now freely available, and we find that the public engages with it and interrogates it and asks questions of it and wants to use that information. At the same time, we've seen scientific networks develop around the world. If I take vaccine studies as an example, the Oxford vaccine, which is in collaboration with AstraZeneca, that work we're not seeing clinical trials done simply in the United Kingdom, but there's this enormous international consortium in Brazil and South Africa, a network of researchers which has promoted to enable this trial to take place and accelerate its development. So this is where I want to come to say a word about China, if I may. I know that in the era of President Trump, he called coronavirus the China virus, and you know the situation, the relationship between America and China became very, very fractious. But from my point of view, purely, I'm not interested in the geopolitics, but just dealing with the doctors and scientists in China has been an inspiring part of this story. You know, they didn't have to try and publish their work in international journals. And indeed, some of them were criticized for doing so. But they published their work in another language in journals thousands of miles away because they wanted to get the signal about this disease out to the rest of the world. And that was an act that we should have a debt of gratitude for. So, what it shows is how the Chinese medical and scientific community are now fully part of the international community. And when we hear sometimes our heads of state raising the rhetoric, raising the heat, remember that underneath that, scientists are working incredibly well together in friendly collaborative networks. And that has got to be an advance for humanity.
Thank you. There are a bevy of questions which I'm going to summarize that begin with, will you agree to be vaccinated when the vaccination will be available? And how will one know which vaccine to take if there are multiple ones? How will safety and efficacy be measured? Will standards be different in different countries, et cetera, et cetera?
Right, these are great questions. So the situation right now, as I mentioned, 11 vaccines are in final stage study, but 6 vaccines have already been provisionally approved and are being used in some countries. And those vaccines have not been through final stage clinical trials yet. So that is in China, that is in the United Arab Emirates, and in Russia. In those 3 countries, vaccines which would not receive approval in Israel, the United States, or the United Kingdom are currently being given to citizens, in particular military groups in those 3 countries. Now, my worry is that if something goes wrong with those vaccines, if there's an adverse effect that we didn't detect in the very early stage clinical trials, and we then discover it, that is going to puncture any confidence people will have in a COVID-19 vaccine. So we really have to be careful at the moment. We should not be cutting corners. This is not a moment to cut corners. Yes, I want a vaccine as quickly as possible, of course, as much as the next person. But if we cut corners and make a mistake, then we will really, really harm the effort to get a safe and effective vaccine. If we get one, would I take it? Absolutely, I would. But I'm not I'm not one of the people who's most at risk. I'm 58 years old, and the people who are at much higher risk are people over the age, it's getting more towards the 70-year-old age range, and people who have a much more active chronic disease, and people who are relatively living in poorer sections of our society. So I'm not one of those people. So the people who should be getting it first are health workers, because they're on the front lines, and then older citizens who have, and those who have chronic illnesses. So, and we do know the kinds of levels of effectiveness that we need for a vaccine. Conventionally, we say that if a vaccine is 50% effective, that's good enough. It doesn't have to be 100% effective. If it's 50% effective, that's good enough. You know, people are quite surprised about the Pfizer vaccine today, because to come up with the very first vaccine, and if it truly is 90% effective, that's actually a big result. That's a really significant result, because that's not the usual pattern. You don't usually get such a highly successful vaccine in the very, very early stages. So this is why I'm cautiously optimistic about the vaccine, because let's wait and see.
There are a number of questions related to the efficacy, which relate to the mutation rate of the virus. There seems to be a second variant, which is going through Europe now, which differs from the spring virus. And it's probably too early, I would think, to make a generalized comment about the mutation rate, but what is the expectation at this point?
Well, there's no question that the virus mutates. I won't go into the technical details, but it's what we call an RNA virus, and RNA is less stable than DNA, and that instability, to put it like that, means that you do have mutations. We don't know yet over time whether it mutates in a way that we're going to have, like influenza, a new vaccine every year. That would not be a good situation to be in, but we don't know the answer to that yet. But we do know it mutates, and we do know that these mutations are associated with different forms of disease. So we published a paper a few months ago. There was a mutation in Singapore, and the disease type, the COVID-19 disease, was less severe than the wild type virus. So that's interesting. Different mutations associated with different severities of disease. So we're going to have to wait and see. There is no final verdict that we can give at the moment about mutations. In Europe right now, we're worried, and we just in the United Kingdom put an immediate travel ban on Belgium because there was an outbreak of coronavirus in mink, so in an animal population. And this coronavirus infection in mink had come from a human being, gone into mink. There's now been a mutation, and it's now been reinfected human beings again. And there is a concern about, you know, this virus originally jumped from an animal to a human being. It's what's called a zoonosis. It jumped from an animal to a human being, and it can continue to jump from animals to human beings. So we have reasons to be anxious about mutations and about the interplay between animal populations and human populations in that process.
There is a comment from Germany, which I think deserves a response. It pertains to having people wearing masks. Here in Germany, there seems to be the main problem when trying to stop the spread. We've had a demonstration of 20,000 people against the anti-COVID measures this weekend, and they are getting more and more people not respecting the anti-COVID rules. I thought that was primarily a problem in America, but apparently it is more widespread. Would you care to comment on that, please?
Yeah, I mean, so I think there are several strands in the mask argument. One of the strands is that it seems that there was a government U-turn. In the early part of the pandemic, governments did not recommend wearing masks, and then suddenly they start recommend wearing masks, and governments haven't made it clear why they did that. And the reason why they did that was that the science changed. Early on in the pandemic, we did not appreciate that the virus could hang in the air, literally hang in the air in tiny, tiny, tiny micro droplets. What we originally thought was that the virus was transmitted from our noses and our mouths in larger droplets, and the force of gravity would take those droplets so that they would land on a surface, but they weren't hanging in the air. But these aerosols of micro droplets, you can imagine if you're in a crowded room and the air has these micro droplets, then wearing a mask is important because it protects you, and if you're breathing stuff out, it protects the other person from passing on these micro droplets that might contain the virus. So the science changed, and I think that confused the public. And it confused the public because when associated with lockdowns and physical distancing and shutting down the economy, I think people understandably see threats to their livelihoods and see the withdrawal of their freedoms and liberties as some kind of overreach of government, that governments need to get out of their lives, and that they're somehow using COVID-19 as an excuse for intervening in their lives in ways which are inappropriate. And I understand that, but on the mask question, the science changed, and that's why they've become such an important and necessary part of protecting ourselves and one another. And the mask protests, it's very difficult to understand, but I suspect it is related to the feeling that it's a deprivation of freedom, that somehow people are being, in a way, it's the voice, having their voice taken away from them, to have their face covered. But it's not, it's a simple protection against the biology of viral transmission.
It's extraordinary that it's so difficult for large portions of the population to understand that it's not infringement on their freedom, it's the protection of others. The concept of public health and solidarity in the community simply eclipses their understanding. And I'm curious as to somebody somewhere is going to have to do a study of looking at compliance between different communities, different countries, and looking for some underlying causes, I would hope, because I don't understand it very well.
And there are cultural dimensions, Fred, aren't there? Because if you think about, I mean, you will have traveled to Asia a lot, and I mean, their compliance with wearing masks is not a problem. I mean, I can remember going to countries like Japan and China, and people were wearing masks all the time. This is pre-COVID. And it was okay. I mean, that was normal. It looked odd to me, but to them, of course, it was just I think this was after SARS. People just had a mask as a routine piece of what they wore if they were in certain settings. And that, of course, is the way it's going to be for us now.
A question that's come in pertains to the public health effects of COVID beyond the infection itself: depression, suicide, overeating, domestic violence, etc. Yeah. And of course, the potential allocation of resources towards the pandemic that might be used otherwise. Do you have any comment about that?
Well, the mental health aspects are extremely important, especially, I think, amongst our children and younger people who, you know, it's absolutely right that we focus on the risk groups that I've already mentioned, older people with chronic disease and so on. But the impact on children and young people is really, really huge. And there's a real danger we get this wrong. You know, in the early part of the pandemic, we did close our schools. At least we did in the United Kingdom. Did you in Israel? Did you close your schools in Israel?
Yes.
You did. Yeah. And then your second lockdown, did you close your schools?
Yes.
You did in the second one?
Mm-hmm.
Really? Oh, that's interesting, because in the UK, in the first lockdown, we closed our schools. And then we had this discussion and we said the impact on children from closing schools was just so bad. We can't do this to our children. So in the second lockdown, we closed bars, restaurants, entertainment venues, theaters, cinemas, and so on. But we've kept schools open. And we've done that on the grounds that if there's one group in our society that we really have to make sure we provide some continuity for, it's children at school. And part of that is the education, but part of it is also to do with mental health. Has that been an active debate in Israel?
There are increasing resources being given towards mental health, which I personally happen to be involved in.
Okay.
But there's clear statistical evidence that we are in a depressed state.
Yes.
Socially. There's no doubt about it.
Yeah, absolutely. And I mean, this is, I mean, there is this phenomenon called long COVID, which we've spent a lot of time talking about here, where in a proportion of people, symptoms of exhaustion and fatigue and fogginess, mental fogginess, have lasted for not just weeks, but months after infection. And we don't know what the long-term consequences of infection are. It is going to leave a shadow over our population. And I'm sure the mental health dimensions will be a significant part of that.
For sure. This again from Germany. What are 3 things that Asian countries did better in controlling the virus, and what can we do? And how important do you think are warning apps?
Right. Well, so what Asian countries did well was they didn't forget. And what I mean by that is that when SARS struck in 2002, 2003, that scared the living daylights out of China, Hong Kong, and many other surrounding countries, Vietnam, South Korea. And the reason why it scared them was that this was a very nasty virus. It didn't kill anywhere like the number of people COVID-19 has killed, but at the time it was really frightening.
Mortality rate was higher.
It was higher, indeed. And China, having just praised China, now I'm going to criticize them, because in 2002, 2003, China handled this situation absolutely abysmally. I mean, they tried to cover it up. They lied to the world. And it took Gro Harlem Brundtland, who was Director General of the World Health Organization, to call them out on it internationally. And China was humiliated on the international stage. And the one thing Chinese leaders said after that was they were never going to allow themselves to be humiliated like that again. They'd already had a century of humiliation, and they weren't going to be humiliated by another virus. So that's why when the outbreak started in Wuhan, they jumped on it very, very quickly once they'd figured out what was going on. And that was a lesson learned in Asia. And as I may have mentioned earlier, we saw the threat not as being a coronavirus, but as being the influenza virus. And so we got it wrong. And it was only when the bodies were piling up in Italy that people across Europe thought, oh my God, this isn't influenza after all. This is something really, really bad. And that's when, and that was in early March. And that's when we started to take it seriously. So I think the other aspect of this is, of course, that in Asian countries, the public is much more compliant with government authorities. I mean, I'm very glad that I live in a democracy, but sometimes democracies have downsides. When you have a pandemic, a slightly more authoritarian culture can be much more effective. I mean, right now, the UK's in a mess, partly because we've politicized the debate and we have Conservative versus Labour Party with different strategies, and the public's divided, and we're in the middle of Brexit. I mean, it feels hopeless sometimes.
But it pales in comparison to what happened in the United States, if I may make an outrageous claim. I'd like to get back to a comment that you made earlier about how in a post-pandemic world, things change. And one of the most obvious changes, which is occurring already, is the way medical practice is being conducted. Face-to-face meetings between physicians and their patients is at a markedly lower level. Telemedicine has become very dominant. And that's probably going to have some very strange repercussions. Do you have any comment about that?
Yes, I mean, on the positive side, I mean, we've accelerated the digitalization of medicine, which would probably have taken a decade, into 10 months. And I mean, it's much, it can be a much more efficient system. So that, I think there are some benefits to it. I think, though, you know, we shouldn't, I mean, I don't practice medicine now, but I used to. The importance of face-to-face communication, it seems to me, shouldn't be underestimated. Being able to look a patient in the eye and then to look you in the eye, to have that relationship, because it is a relationship. There is a therapeutic relationship that develops between practitioner and patient. And I think if you can't reproduce that on Zoom or Microsoft Teams or whatever it is you're using. And another part of it, which I think also gets underplayed in the modern medical technology of everybody getting a scan for everything, and that's the importance of touch. You know, the examination of a patient, as well as taking a history, that examination, the connection between the doctor and the patient when you examine somebody, again, that's all about building trust in a relationship. And you can't do that on Zoom. On Zoom, you can have a purely transactional exchange, and sometimes that's all that's needed, but not always. So I think we need to get to an equilibrium where we use technology appropriately, but we don't allow it to marginalize what are actually some very important human aspects of medicine, which I think are central to the practice of our profession.
Here in Israel, there has been a lot of finger pointing about the resources placed into the healthcare sector, that we have not developed enough hospital beds, enough physicians and nurses, et cetera, And one of the post-COVID political effects, I would think, is a reassessment of what any particular country needs. And I wonder if you have any preliminary thoughts about that.
Well, actually, you know, it was 3 years ago now, 2017, I was in Israel because we'd been working with a team at Rambam, but also across the whole of Israel, to produce a series on the health system in Israel. And one of the issues that we raised in that series, we had a group of about 30 or 40 Israeli physicians. We did it partly with the Ministry of Health, but a little bit separate from them. And what we were arguing in that series was that health is not a political priority in the way it should be in Israel. That actually, for a country which is so punches above its weight in terms of science, which it does, strangely, there hasn't been the attention paid to the health system. There are some things actually that are very good. You know, the Khalit and the other funds have done a fantastic job in terms of, again, talking about digital health, in terms of the digitization of data. But investment in the health system as such has not traditionally been a political priority for governments. And we argued in that series that health needed to be taken more seriously. But I appreciate the context is very difficult, that, you know, there are other things to be concerned about if you're the Prime Minister of Israel. But at the same time, maybe this is a good thing that will come out of COVID, health will be taken more seriously.
Okay, we don't have much time, but a mother here in Israel asks, what about post-COVID cases, especially with children who suffer from severe illness and it turns out they are asymptomatic with COVID? Any insights about this in terms of medical research, when it happens and why? That idiosyncratic young person is problematic, isn't it?
Yes. Well, the situation with children is complex. So a general statement, young children, if they become infected, are commonly asymptomatic and don't suffer severe, very small proportion will suffer noticeable or severe illness. A very small proportion, on the other hand, do develop a syndrome, which is a very unpleasant syndrome. It's often associated with overweight or obese children. And it's a syndrome that's like a disease that we've known about for some time called Kawasaki disease. But that's a very small proportion of children. It's not a big problem that parents should be anxious about overall. But as children, if you go into the older age groups, the teenage years or the adolescent years, then they behave more like adults in terms of the type of infection that they get. And especially if it's associated again with overweight or obesity. This link with obesity is very important. And you know, we do have a population of young people now who are generally overweight and a proportion who are obese, certainly in our society, and I suspect in Israel as well. That's I think all of our Western societies are facing this challenge. So yeah, the situation for children is uncertain. And I think the mental health side, as we spoke about earlier, is perhaps the most important aspect. The physical health side is less important. The mental health dimensions, I think, are more important. And I think, as I was mentioning a moment ago, the more we shut schools, the worse that's going to be. We're depriving children not only of their education, but of their networks with their friends. And that could have a very, very nasty long-term impact.
And most of the complaints come from the parents.
Yeah, well, because the children are at home.
And they can't work, etc.
And they can't work. No, exactly. And of course, that will often fall on, this is where there's a gender equality issue. And because certainly in this country, what's happened is that the burden of childcare fallen on women. So actually, COVID-19 has worsened gender equity, not improved it. So it's, I mean, these are these unanticipated effects.
For sure. I can safely say for this entire group, and there are over 200 people listening, this has been most enlightening. We're most appreciative. And we could go on for another hour, but I'm told that we are to terminate. And so on behalf of the Haifa community, thank you very much, Richard. And we look forward to continuing our relationship in the future.
Thank you. Thanks, Fred. It was great to get to know you.
Pleasure.
Thank you.
Ron, do you have?
Yes, I will just mention for those who are eager to hear more from Richard Horton, come March, and once life is safe again, we hope to resuscitate our honorary doctorate ceremony. And Richard will be awarded an honorary doctorate from the University of Haifa once we can all meet again. Thank you for a brilliant presentation. Thank you, Fred, for being our moderator. We wish you all the best of health and look forward to good tidings. Good night, everyone, or good afternoon, wherever you may be.
Thank you very much, and take care. Be well, stay safe.
You too.
Thank you, Ron. Thank you. Thank you, Fred.
Bye-bye.
Bye. Bye-bye.